My name is Catriona Waitt, and I'm a Professor of Clinical Pharmacology and Global Health, employed by the University of Liverpool, but I do most of my research at the Infectious Diseases Institute in Kampala, Uganda.
Can you tell us a bit more about what that involves?
So, as a clinical pharmacologist, what I'm really interested in is the safe and effective use of medicines. And that sounds like a very simple question, but actually, everybody should have evidence to inform the decisions they make about their healthcare. And there's actually quite a lot of people who never make it into clinical trials. So, often trials are done in a relatively healthy, stable population. And women who are pregnant or breastfeeding or people that have a lot of other medical conditions are often excluded from trials, which I understand why that has been, but it means that if you are a breastfeeding mum and you need medication, you really have very little information. So my research group very much tries to speak into that gap.
Can you describe a typical day in the life?
So that's one of the beauties about my job is that there really isn't actually such a thing as a typical day, because a lot of it will depend what projects are going on at the moment and what opportunities there are. But as a clinical academic, there is quite a lot of paperwork. And what I try to do is I try to start every day. I mean, before 7 o'clock, so before the day has started for many people, I try to do one big writing task. So that might be working on a grant or a draft of a paper or something that requires quite a lot of creative thought. And I find that by doing one solid writing task early in the morning, I then sort of feel more ready for whatever chaos comes up after that. So often in terms of clinical trials, there might be site visits, there might be training, there might be working with junior colleagues, there might be meetings with ethics committees or regulators, there might be having to go through quality control questions. We have monitors that evaluate to make sure that we're actually sticking to the protocol and doing everything to the highest quality. So sometimes there'll be queries to address. Sometimes there are ethics submissions that need to take place. So there can be quite a lot of kind of clinical trial related administration. And then other roles include training. So that could be giving talks, it could be teaching people about clinical trials, it could be trying to explain some of the mathematical techniques we use and why we use them. It could be talking about why it's important to involve communities. And some of the training involves PhD students, spending time with them, looking at their research, trying to train and mentor them. And then, of course, as a clinician, there's always the fact that the reason you have to have physicians on your clinical trials are so that if any participant gets sick, either with an intercurrent illness that might just happen or perhaps a drug side effect, it's really good to be able to go and evaluate them and decide what's happening with them, provide the best clinical care. And so dealing with all of that usually takes up most of the day, but the actual specifics of each day are different every time. And that's one thing that I love about the job, but I can see why some people might find it unpredictable and chaotic. I do try to plan. I do try
Mm.
to plan, for example, Monday is very much a face-to-face day, lots of meetings, lots of face-to-face interaction. I try to put most of my conference calls onto a Tuesday, for example. But I think you always have to be prepared for the unexpected. When you're working with humans, when you're studying human participants, the unexpected will happen. And so you have to be able to respond to that as well without getting flustered and without letting it derail you from achieving the goals that you need to achieve. And I don't know if there's an absolute right or wrong way to do that. But again, I think that's one reason why I like to shift a lot of my writing and things to early in the morning where there aren't going to be unexpected things happening.
What is one thing that you wish the public knew about the work that you do?
I wish the public knew how little information there is about medicine's use in pregnancy and breastfeeding, because sometimes people make an excuse and they use a term like a special population and they say, well, of course we can't do studies in special populations. But I would like people to think about that because half the world is female. Most women go through at least one pregnancy and breastfeeding. And worldwide, more than half of all these women require some form of medication. So it's not actually a minority group. And it's quite inequitable and almost unethical for drug companies to license medication that are likely to be used in women of childbearing age without having actually thought about the safety and the effectiveness of the medication in that group. So I wish the public knew that this is a major issue that affects every population worldwide. And rather than being unethical to study drugs in pregnancy and breastfeeding, it's actually unethical not to do so. But just as we must do the studies, we need to do them with a degree of excellence. And that's what my research program spends most of the time doing, trying to define the safest way of getting accurate information from the smallest number of participants in a way that's meaningful. And I think everybody's terrified, of course, because people would not want to cause any harm to a child. That's our biggest fear. And people remember the legacy of thalidomide. And in fact, a lot of the real clinical trials regulation and medicines regulation came about after that. But thalidomide was interesting because if people had done a clinical trial in thalidomide, the frequency of the adverse event would have been such that it would have only taken 10 or 15 participants before at least one baby was born with a malformation. So whilst that would have been absolutely tragic for that one family or two families, and of course it would have been very hard for the drug company, it would have been significantly better than causing widespread harm amongst tens of thousands across Europe. And thalidomide is also quite interesting because one thing I hadn't realised was that the US, the FDA, they refused. There was a woman called Frances Kelsey who was actually relatively junior at the time, and she sort of dug her heels in and said, no, there's not enough data. She wasn't happy for the drug to be licensed for use in pregnancy for morning sickness in America, so they just didn't use it, and that's why you didn't have any of the thalidomide babies in the US. And it really shows to me, I find that quite an inspiring story because it shows why medicines regulation really, really matters, but it also shows how one person doing the right thing can actually have a massive and significant impact. So the fact is, if a trial had been done, we'd have known much earlier on that there was a major problem. And of course, you don't want to go in and start doing trials of new drugs straight away in pregnancy or breastfeeding. There's a lot more to it than that. There's animal data, there's cellular data. It's really only if a medicine is going to be needed for her own health. So, for example, imagine you had a pregnant woman who had a life-threatening illness. Sometimes I use the example of Ebola. So Ebola, if you get Ebola when you're pregnant, without treatment, you're almost certainly going to die. And the baby will definitely die without treatment. I don't think there are any babies who've survived maternal Ebola without treatment. So if a new treatment comes along, even if that treatment was quite risky, you would be happy to take that risk because you're comparing a potential risk of a new drug against the almost definite risk of death. So in that kind of situation, the risks and the benefits are such that you would take the risk. Whereas if it was a medicine for something like hay fever or something, of course you wouldn't want to take a risky medication when you were pregnant. You'd want to go with something that we knew was safe. So there's a lot of complexity, and I could talk about it for a very long time, and I won't. But I think it's very important that we communicate clearly with the public and with our stakeholders that we're not doing experiments on pregnant breastfeeding women, but in fact we're trying to prevent harm.
What qualifications have you found to be useful, or would you recommend to work in public and global health fields, and specifically the field that you're in?
I struggle with that question slightly because I don't know that it's necessarily a qualification as such. And sometimes having a qualification without the experience can actually be a bit misleading. So you can end up in a situation where somebody might have an extremely impressive CV of qualifications, maybe even distinctions and prizes in their qualifications, but they've not actually got that real world clinical experience and exposure that really equips them to do the job. So I think I have to probably caveat anything I say about qualifications with go out there and get some experience. So I've lived predominantly in Uganda for the last 10 years, and before that I was in Malawi for 4 years. And I felt very strongly that if you're going to do global health research, you have to be able to understand the context and the culture in which you're living. And if you start to unravel culture, there's the very superficial things that you can see. So there's things like the way people dress, the way people eat, the public holidays that are celebrated, the national religion. There's the things that you can see. But when you go a step lower, there's all the layers that you don't see. There's all the worldview, there's all the complexity. And it's really hard to learn about that without actually being embedded in the midst of it. So understanding that actually that woman doesn't have a choice because of her family dynamics and the community she lives in. She isn't free to make some of the choices that perhaps we as Western women might be able to make. But at the same time, she might not feel oppressed by that because to her, that is her reality. And it's very easy for us to perhaps come in and make a judgment on a situation or even run the risk of trying to give advice when we just don't even understand. So I think I would be very careful with global health that you question, why is it you want to do this? Why do you want to leave the country of your birth or perhaps your passport country and work in a different part of the world? Like, what is it that's motivating you? And why do you want to work among that particular people in that particular country? Is it just opportunity? Is it that you're fascinated by a disease and you want to go where that disease is endemic? Is it seeing inequity and injustice and wanting to actually stand up for that? But what is your motivation? And then being very careful when you go somewhere to listen really carefully to what people are saying, to make local friends that you can actually ask the really obvious questions like, please, can you explain that to me? Why does this happen? Why is it that, things that just seem so frustrating at times, but when you understand, so I think match your qualifications with experience. But in terms of qualifications themselves, of course, diploma in tropical medicine and hygiene is always fantastic. You can do that in London or Liverpool. I would go and say Liverpool is the best. It's a young, vibrant city. It's dynamic and it doesn't have the chaos of London. But I'm of course biased because that's why I did my own in 2004. I find that a very useful time as a doctor because so often when you're in your junior doctor years, you're so busy with the jobs basically, and you're tired and you're often perhaps buying your first house, maybe you're getting married, but there's just a lot of pressure and you don't often have that time to just sort of stop and think about what you're doing. Sometimes it's being on a treadmill. Doing the diploma in tropical medicine gives you 3 months to sort of really immerse yourself in a cohort of other people that are also asking questions, wanting to work in different places. You're hearing the experiences of those that have worked overseas. So you're not just learning about the diseases and the epidemiology and all of the actual technical work, but you're actually learning those experiences and you're reflecting and you're thinking about how you want to live. And then perhaps after doing something like diploma in tropical medicine, perhaps trying to do something like an internship or a placement or a short project somewhere if you can.
What path did you take? So how did you get to working in Uganda on pregnant and breastfeeding women? What was your kind of path into global health?
Goodness. So again, this is one of these questions where there's often the long story and the short story, and there's often a combination between choices and things that happen as you go along the road. But I suppose I always wanted to work somewhere where I saw inequity. And I was always quite aware that just because people are born in one part of the world, they have access to better vaccinations, healthcare, education, just a generally better standard of living. And other people whose lives have just as much dignity and value are not able to access the same things, and there is so much inequity and disparity. So I had this sort of feeling of somehow wanting to make a difference, and I had been overseas a couple of times as a medical student doing electives and things like that. So when I was trying to work out what I wanted to do, I wanted to make sure I worked on a problem that was like a real problem. I didn't want it to be some sort of academic. Some research questions are obviously they're all pieces of a jigsaw, so I'm not saying anybody's research doesn't matter, but sometimes it can feel a little bit obscure and a bit removed from the patient. So as a junior, and about the time I did my MRCP, one of my professors suggested I go out to the unit in Malawi, where the Malawi Liverpool Wellcome Research Programme is. And I spent 3 weeks there, and what I was seeing was people who were basically younger than myself, just dying, because these were in the days, this was 2002, so antiretrovirals and the Global Fund hadn't really got to Malawi. So HIV at that time was still pretty much a death sentence. And a lot of what people were dying of was tuberculosis, disseminated tuberculosis. And one of the questions was, why is it often after you started TB treatment, people would kind of deteriorate and go on to sort of die quite rapidly? And so my whole PhD and my whole research was on that very question. So after returning from that pilot visit, I wrote a Wellcome Trust clinical research kind of PhD proposal. It was in those days called a training fellowship, and off we went to Malawi for 4 years. So during my time in Malawi, I had my first 3 children and then returned to Liverpool to finish my training. And round about the time I had my 4th child, I was also trying to get my research going. I was dealing with this young family. I'd been quite ill myself, and I remember just feeling like my research was getting more and more cellular and immunological and further away from the patient, and that's the thing that I hadn't wanted to do. And with this 4th pregnancy, I was in hospital about 10 times, and I was pretty sick, and afterwards had to have quite a lot of surgery, and I was on a lot of medication, and there was no evidence for any of it in breastfeeding. And I remember one day sitting in one of my professor's office, and we were just talking about that. I was breastfeeding the baby, and the baby was sick, and we were talking about how can you tell how much drug gets into the baby if the mother's breastfeeding. And I thought this question must have been answered for antiretrovirals, because most women living with HIV have no choice but to breastfeed their babies because they live in parts of the world where breastfeeding's the norm. But I went home that evening kind of sort of fascinated by this, and I realized that very little work had been done, because a lot of the HIV advocacy at that time hadn't been from women's groups. It been sort of like from the US male, perhaps homosexual population, who'd done a lot of excellent advocacy. But the breastfeeding women in Africa seemed to be kind of forgotten. And I think it was at that moment there was this intersection between some of what I was experiencing personally, my skills as a clinical pharmacologist, this area of complete injustice and inequity and a complete gap in the data. And I just thought, I can do that, I can fix that. So whilst I was still on maternity leave, I wrote a starter grant to Academy of Medical Sciences. So I was able to get £30,000 in 2 years to sort of start some of this work going. And that took me to Uganda for the first time. And whilst that work was going, then I got another Wellcome grant to sort of expand the maternal and infant lactation pharmacokinetics work. Then I got another Wellcome grant to continue that work, and I got some public engagement funding. And more recently, I've got a large grant from NIHR. So it's just kind of that intersection. I think the Japanese call it ikigai. It's the intersection between what you're passionate about, what you're good at, what the world needs, but also what you can make a living doing. And when it comes together, you just think, yeah, that's what I'm going to do.
What would be your one piece of advice for kind of aspiring students who want to kind of follow in your footsteps?
So maybe my one piece of advice would be not to follow in my footsteps at all, but to find your own footsteps, because I think sometimes that can be a challenge. I remember when I was relatively junior, I didn't see that many role models of perhaps women, people that I felt I could really relate to, and I couldn't really see anybody who was doing the kind of thing that I'm doing now, I suppose, because as well as being a professor of clinical pharmacology, I'm also a mother of 5. My husband's also a clinical academic, and we homeschool our children and we move around the world, and we sort of have this slightly complicated but kind of exciting adventure of a life, which I would have absolutely no regrets about. But I never saw anyone doing that. And I don't necessarily know that you should replicate that, but maybe what you should do is what works for you according to your interest, your career interest, your relationships, your family, your health, all of your circumstances. So I think seek out role models and mentors, definitely, but talk to a lot of people. But remember that in academia, particularly, the job you end up doing might not yet exist, and sometimes it's carving your own path. The second thing, like scientifically, somebody said to me early on when I was working with the Academy of Medical Sciences on that grant, somebody said to me, you have to find that thing, that area that just really bothers you. You just wake up wrestling with the idea. You kind of almost can't rest until you find a solution. And whilst I enjoyed my PhD work and the TB immunology was quite fascinating and I found some interesting things, it didn't really make me tick. But this question about drugs in pregnancy and breastfeeding and the safety and bringing together the different aspects of clinical pharmacology and mathematical modeling, public engagement, that is the thing that makes me tick. But it took me a little bit of a time. I mean, I told you there's a long story and a short story and the post-PhD wilderness and, a few years of really not being sure what I wanted to do. It might take you a while to find that thing, but I think when you find that thing that you just can't let go, that's what motivates you and that will help you overcome any challenges and obstacles along the way.
What would you say is the most rewarding part about your job?
The most rewarding part of the job is when you start in a community group. Maybe I'm sitting with other mothers from other parts of the world and we're talking about priorities and they say something like, I really wish there was evidence about this particular drug in pregnancy or breastfeeding, or in the HIV world, people have really want to know about long-acting antiretroviral drugs. So the community tells you something, and you take that and you think about it, and you go away and you eventually get some funding, and you do a trial or a pharmacokinetic study, and you get the data. So about 5 years later, maybe longer, to be able to sit in a room again with a similar group of women, some of the same women, and be able to thank them for raising the priority and tell them that you've taken their concerns, you've now got that data and you've filled that gap in partnership with the community. To me, that feels entirely meaningful because the research is very applicable and relevant to the patient. I think I mentioned at the start, I always wanted to stay kind of engaged with the patient. So being able to kind of complete that circle and go back and actually tell them what you found, what it means, why it matters, and have their sort of delight in now my question has been answered. And I kind of feel like if I can go around that loop a few more times before I retire, I'll be quite happy.
So how do you see the field of pregnancy and breastfeeding and pharmacokinetics within pregnancy and breastfeeding? How do you see that evolving in the next 5 to 10 years?
I think there's been some quite encouraging progress over the last decade or so, particularly with changing guidelines from the US FDA and some of the clinical trials kind of guidance and advice that really, if you expect a drug may be used by women of childbearing potential who may become pregnant and want to breastfeed, you really should get data around about the time you license the drug. And if you look at the amount of time from a drug coming on the market to getting data, it's at the moment very long. So last year we published some data on rifampicin, well-known anti-TB drug. 52 years after drug licensing, we were able to publish some breast milk data. And why should it take half a century? But we're starting to see that gap being closed. And I think this requires partnership between pharmaceutical industry, academia, national drug regulators, patient groups, and there's also the whole equity of access to the drug side of things that, of course, it's not right to study a medication in a population who are never going to get that drug. But I feel like this kind of multilateral partnership and changing legislature and increasing scientific skills, so some of the computer-based mathematical modeling and simulation tools are actually becoming better and better all the time. So I feel like we are getting better. And I think over the next decade, I think we're probably going to see an acceleration of the progress because I feel it's a bit like, I don't know if you've ever seen giant bamboo, but you have just a little bit above the ground and then for ages nothing seems to happen. But underneath there's loads and then one day it suddenly just like shoots up and you get about 10 new shoots at once and before you know it, it kind of grows a meter a day. I know I have one in my garden and I don't know if planting it was a good idea, but I think clinical trials in lactation are probably a bit like giant bamboo, that there's over the last decade there's been an awful lot going on kind of beneath the surface that if you're in the field you'd know about it, but you're not quite seeing it yet. I think we're going to start seeing a lot more and maybe you could ask me in 10 years and I can do an interview with you.
Thank you so much, Catriona, for the interview today. It's been really interesting just to hearing from your perspective and about your career journey. Any final words?
Just that I hope that if you're listening to these career interviews, that you are enjoying them, finding them helpful, and people who give these kind of interviews are usually happy to be contacted too. So if you do want to discuss any of this further, you can reach out by LinkedIn or any of the other social media platforms. And the fact is, people people who love what they do are usually really, really keen to inspire others to be able to do something similar and to have the fulfilling career that they've had. So don't be shy in reaching out to people. We were all young once and we all went through times of uncertainty and we've all hit roadblocks. But actually, it's that kind of teamwork, that spirit, that mentorship, that kind of traveling along the road together that really helps. So make the most of the podcasts and good luck.